Right, hi everyone and welcome back. Thank you for rejoining us so promptly. So this is our next session, or the first sort of taught session, and we're going to be talking about A to E assessment. So just to reintroduce myself, my name's Jo. I split my job 50-50 between being a Band 7 on PICU at Evelina and being an RMP for STRS. So I'm sure I've met many of you guys out and about. So let's go through the aims of this session. So we're going to be looking at, if my slides would move on. There we go. So we're going to be looking at how we apply an ABCDE approach to a systematic assessment. I appreciate that you guys will have been taught this in other sessions before, in PILS and APLS. We're going to look at it particularly looking at care of critically ill children. So we're going to look at how, when we're using our A to E approach to systematically assess a child, how that can show us altered anatomy and physiology, and look at some examples of that. How it aids us in recognising and responding appropriately to a deteriorating patient. During the slides, there will be some questions, which I really want you guys to respond to, because we're going to try and make this as interactive as we can. We know it's strange for all of us doing this in a virtual world, but there will be questions that come up. So if you can type those in, answers to those, and if you have questions going along, then please use the kind of raise your hand icon and then unmute yourself to ask any questions as we go along, because I'd really like this to not just be the sound of my voice for the next 50 minutes or an hour or so. Okay, lovely. So first of all, we're going to look at these don't want to move on. So we're going to look at each stage. We're going to look at what we're assessing, how we assess it, and what signs will show that something's unusual. So we're looking, first of all, obviously A is for airway. So what do we want to know about an airway? We want to know if it's patent. We want to know if it's not patent, is it completely obstructed, or is it at risk of becoming obstructed? So when we first assess a child, when we go up to a child or a baby, if they've got an audible, loud voice, a strong cry, and they're conscious, we can be reasonably happy that they have an airway that at the moment is patent. But if we're not happy with that, how do we go on and assess to find out what's going on with their airway? So we do that by looking, we do that by listening, and we do that by feeling. So we look, you can get an awful lot in looking at any system of a child's body by standing at the end of the bed and looking at them and look what's going on. So is their chest movement? Does it look like they're getting air in and out? We do have to take that with a bit of a pinch of salt and actually listen as well. What's their respiratory pattern like? Does it look normal? Does it look obstructed? Are they using their abdominal muscles, their chest muscles? Does it look like they're forcing air in and out and they're struggling to get air in and out? We listen. So normally, if a child hasn't got an obstructed airway and they're breathing comfortably, normal breathing is very quiet. Are there additional noises? Is there something else that we should be concerned about? And we feel. Can you feel expired air coming in and out of their mouth? If there isn't any evidence of air movement, obviously, we need to go on to emergency procedures, airway opening, positioning of that infant or child into the appropriate position, suctioning their airway and using adjuncts and taking over their breathing if necessary. But in the case of a child whose airway is obstructed or partially obstructed, but they are managing to get some air in and out, what signs do you notice? What do you see in children that you've looked after that shows that they might have signs of airway obstruction? So if you can just share some of the things you've seen when you've been looking after children that have got obstructed airways. Okay, Rebecca.
Stridor.
Stridor, yeah, excellent. So stridor, definitely. We'll discuss them all when we go on to the next slide. What else have people seen? What other signs have people seen?
Recession, intercostal, subcostal recession.
Sorry, I've got two. So we've got recession, yeah, absolutely. Different forms of recession. And what was that, sorry, Sarah, that you were showing from the... So grunting, cyanosis, head bobbing. It sounds like you guys are covering lots of it already. So signs of airway obstruction. This might not be everything. So if people have got other things to add, then please continue to add into the chat or by raising your hand. So signs that we might have airway obstruction. So stridor was the first one that came up. Stridor can be inspiratory, it can be expiratory. It's a high-pitched noise, isn't it? And the most common stridor we hear is the inspiratory stridor, which I'm not going to demonstrate particularly on an audio in a virtual world, but we're all familiar with it. We've heard it. Children with croup, children with other upper airway obstruction. So traditionally it's inspiratory, and that means it's something extra thoracic. So it's something in your trachea or laryngeal airway. It can be expiratory as well. Now that can be because your croup or your whatever your reason for your upper airway obstruction is getting worse, and that's a really obviously worrying sign if it's become inspiratory and expiratory. Or if it's just expiratory, then it means that the obstruction is lower down. It's something intrathoracic rather than something that's in the higher airways. Stertor is another noise that people talk about with airway obstruction. And people often get the two confused. And stertor is more like a snoring. It's more like a pharyngeal, and it's a much lower pitch noise that you hear with airway obstruction. You know, obviously lots of people have snoring or large tonsils, things like that can cause a stertor. Accessory muscle use, which one of you said, and we talk about, you know, when someone's really struggling to get air in and out, you can see them using abdominal muscles, you can see them head bobbing and really trying to get the air in and out. And tracheal tug, again, is something we see quite a lot, isn't it, with airway obstruction. Gurgling of secretions, I think someone mentioned that as well, didn't they, in the chat too. So if someone's really struggling, got a really obstructed airway, gurgling or drooling you can see in children as well. Posture, I'm not sure if that got mentioned, but if you think of babies you might have looked after who have got obstructed airways, they can sometimes really lie in a kind of quite an extended position. Even very young babies will know how to get themselves into a position where their airway is clearest. Or older children that you might see, particularly those maybe that you may or may not have come across them, children with mediastinal masses, various things that are obstructing lower airways or upper airways, will sit in quite a, you know, sit facing or sort of leaning forward. They can't lie down because that makes the airway obstruction so much worse. So these are all kind of things that might highlight to us that there's really something quite significant going on with someone's airway. Cyanosis you mentioned, that's as you guys will be aware, it's a really late sign. A very, very narrow airway can get enough oxygen to maintain saturations generally. So if you've got a child, like a child with croup or something, who you're concerned about their airway and they're starting to become cyanotic, they're in real trouble, and you need to escalate their care really quickly. And as we can all imagine, if you can't shift air, if your airway is obstructed, agitation, panic look on their faces. And then when you auscultate or actually listen to their chest, like we talked earlier about is their chest moving, but sometimes if you listen, actually the exaggerated movement of their chest is not indicative of how much air they're actually moving. And actually when you listen, they've got really poor air entry or a silent chest, no air entry at all, which obviously is an emergency that needs to be responded to. So those are the signs that I came up with airway obstruction, but you may think of others as well. So what are the different causes of airway obstruction? And there are many. We've mentioned a couple already. So croup is one of the classic ones that we see a lot of in the kind of 6-month to 3-year-old age group. I've broken them down into kind of acute and chronic causes of airway obstruction. It's not the purpose of this session to discuss all causes of airway obstruction. It's more about how we're assessing them. Think of children you might have seen with some of these conditions and how did they present? And then if you think, like we've talked about already, croup is upper airway. So you're going to hear that high-pitched stridor, whereas a child with a lower airway obstruction, say a child with a vascular ring, which you might have come across before, or a child I've talked about previously where they've got a mediastinal mass because of first presentation with a lymphoma or tumour, they're going to have lower airway obstruction, which more traditionally is therefore a wheeze and on expiration. So the different symptoms that we see will be related to where that airway is obstructed. I hope that makes sense. Please raise your hand if any of this doesn't make sense. The last slide on A that I just wanted to briefly put in was looking at children who might potentially have difficult airways. And these are children that maybe don't initially present with the signs of an obstructed airway, and they may have another disease process going on. But if you're going to have to do anything about their airway, it might just think about highlight to you the fact these children might be a real problem if anyone has to do any airway interventions. And that's children both with an acute disease or illness or reason that's brought them into hospital, be that so something like a burns or smoke inhalation or head or neck trauma. Certainly we know that airways can become swollen and obstructed very quickly after a child's been burnt or had smoke inhalation. Head and neck trauma, we know that positioning of the airway has to be managed very carefully, and as you guys will know, that's with jaw thrust rather than and avoiding extending or flexing the neck. But also children that have got history that's particular to that child. So classically, I think, are the ex-preterm infants that turn up with bronchiolitis when they're 6 months old, who, if in their history they were ventilated for a period of time as a newborn, then they may well have subglottic stenosis that we're not initially aware about. But if you go on to have to intubate them for other reasons, for their breathing difficulties, then we may have problems with intubating them. So it's just thinking about their airways. Children who are dysmorphic as well, we know that if they've got recessed chin, they can be difficult airways to manage. And then the last mention is we've seen lots and lots of children now, don't we, with tracheostomies. They're becoming more and more common. But obviously it's just knowing the reason for why that child's got a tracheostomy and do they have an intact upper airway. So if you're running into problems, what are your options with that child's airway? Right, so that's airway covered. Now we're going to talk about how we assess a child's breathing. So moving on to B. So like we talked about, we want to know what we're assessing. So what we're assessing with breathing is what's their effort of breathing. So what's their work of breathing? We talk about that all the time, don't we? Not just what their work of breathing is, but what's the efficacy of their breathing. So is it effective? Is what they're doing, is their work of breathing actually effective for them? And then looking at the effect that their breathing or their compromise in their breathing is having on other systems of their body. So if we talk about effort, when we're assessing children, we do it, all of us do it every day in our nursing practice. You look at their respiratory rate, don't you? You don't just look at their rate. The joys of paediatrics is a rate of respiration a newborn baby versus a 16-year-old. Clearly, different rates are appropriate for different ages. You also want to know what's the trend in that rate, not just a one-off value. Do you want to know, is that rate getting quicker? Is that rate slowing down? Does that show that the child is deteriorating or improving? You also want to look at the depth of their breathing. Is it very shallow breathing or is it appropriate depth? Are they moving their chest well? And what's the pattern of their breathing? So we've already talked about obstructed breathing patterns that you might get with airway obstruction, but you might get different breathing patterns with different disease processes as well. So recession. So children, particularly up to the age of 5, quite easily have recession, don't they? Intercostal, subcostal recession, tracheal tug. It's not effective. It's not actually helping their breathing, but it shows that the effort they're putting into breathing. Accessory muscle use we look at babies that head bob, children that sit themselves forward, again like classically your asthmatics, using every muscle they can to try and get air in and out, and nasal flaring. And then we talked about upper airway noises, and we did talk a little bit about lower airway, but when the effort that they're putting in, can you hear wheeze, can you hear anything else when you're assessing the amount of effort they're putting into their breathing? They also might adopt a posture that is improving their ability to get air in and air out. Can you think of any exceptions to this? Can you think of children that you nurse, children that you've cared for that might not exhibit the usual signs of respiratory distress? So if you're able to maybe start typing those into the chat, any examples you can think of. And I think the things I've put on the bottom of that slide that I was thinking about is when you are assessing these children, when you're assessing their breathing, children that are struggling to breathe, they're having increased work of breathing, you want to think about sitting their bed up, making it more comfortable for them. Children do adopt the position that makes it easiest for them to get breaths in and out. Young babies, toddlers, upright in parents' arms. You don't want to be lying them flat on the bed to assess them because you're going to make respiratory distress much worse. And obviously, you're going to be administering high flow oxygen if you're concerned about their respiratory effort. So just to put that question out there again, can anyone think of any children that they have cared for that haven't been able to exhibit those signs of respiratory distress? Any particular groups of patients? So compensating. So yeah, so they might show some signs rather than all of them. So yes, you might start to get an increased respiratory rate, but actually that's pretty effective and you haven't got other things going on. Yeah. So other suggestions we're getting coming in, as you guys can read, are things like, so that's exactly what I was thinking of. So it's just to be aware that when you're doing your assessment of the amount of effort they're putting in, that there are groups of patients that we probably look after more and more who actually aren't able to show those initial signs of respiratory distress. So they may have got to the point that the first time you meet them, they're so exhausted, they're so fatigued that actually their respiratory rate has slowed down and they're not making a huge amount of effort, and actually obviously that's extremely worrying in a pre-terminal stage. But it might be that they've got neuromuscular conditions, so children with the muscular dystrophies, as people are suggesting, or spinal muscular atrophy, so different conditions that actually just don't have the muscle ability to show that work of breathing. So those children may appear to really rapidly deteriorate because we've perhaps missed the signs prior to that. And it just highlights the need for a really thorough examination of not just the effort they're putting in, but also the effectiveness of their breathing.
Thanks. Emma's just mentioned ascites, Joe, and I just wanted to come in there. I guess ascites is slightly different. It's a good answer, and it's really good to think about, especially I think, Emma, you work in liver. So the issue with ascites is that actually what is normal for that patient when you have a big belly is not necessarily what's normal. So we adjust our parameters, we adjust what is normal for that child. So they'll have low tidal volumes, high respiratory rate as a normal setting for them. So when they do run into trouble, we have to think about what is normal for them and when is a respiratory rate going up higher. So they have less ability to expand the depth of the breath that they take, so their respiratory rate might go from a normal of 60 to a normal to 80, and that's where we have to adjust our thinking for those patients. But they can exhibit signs of respiratory distress.
That's brilliant, though. Thanks for sharing, because those are kind of, I mean, those aren't the sort of patients that I'm used to looking after on the unit that I work in, but it's great to share the experiences of what we've seen. And that certainly that abdominal distension that you get with ascites, you'll see in other conditions as well, won't you? Like children that present with acute abdomens that will impact their respiratory function an awful lot. So it's great to share these things. Okay, so what we've highlighted there is that the children that can't show those initial signs of respiratory distress, that aren't able to demonstrate that work of breathing because they don't have the muscles to do so, or because their level of consciousness is decreased, they just highlight the need for the thorough examination of the effectiveness of their breathing, which is what we're going to talk about next. So that work of breathing they're putting in, is it actually being effective? Is it actually getting the air in and out, saturating them, and everything, and what we want their respiratory function to be doing. So how do we assess the efficacy of breathing? So again, I'm going to say it again and again, we look, we listen, and we feel. So we want to know how much air is being inspired and expired. So what are their tidal volumes? Are they getting a good amount of air in and out when they're taking breaths? So we can do that by looking. We can do that by looking at their chest expansion from the end of the bed. As I say, that doesn't necessarily mean the amount of air they're getting in. Sometimes it's the effort they're putting into it. You can listen, auscultate, get your stethoscope out and listen to how much air is going in and out. And for those of you that aren't used to auscultating regularly, then it's something to really get into the habit of, because when you do a good patient assessment and then the child deteriorates, you can notice a real difference when you get your stethoscope out again and listen, and it will give you a really good idea as to what's going on with that child. Lay your hands on their chest. So that's what we talk about by feeling. When you put your hands around the child's rib cage, you can feel whether you've got good chest expansion. Are both sides rising and falling equally? So it'll give you a good idea, if you're not used to auscultating. Both of them will give you a good idea as to whether you're getting equal air entry both sides. And then we're also listening not just for air entry, but have we got any abnormal added noises as well? So can you hear the popping sounds, the crackles of secretions, or have you got no air entry in particular areas that will suggest a disease process or things that might be going on? But again, when you're putting your hands on and feeling, you can feel those secretions. We all know that the feel of secretions in a child's chest as well. So you just get an awful lot from putting your hands onto a chest, feeling their chest, feeling the expansion, feeling for any secretions, and then auscultating as well. We also want to know what their oxygen saturations are. Cyanosis is a very late pre-terminal sign, and depending on where you read it, 70%, 80% saturation before you really see that a child is cyanotic. So we want to be monitoring their oxygen saturations, don't we? And how much oxygen are they in? Oxygen saturations of 92 in air might, give us a little bit of cause for concern. It's not normal in most patients, but if it's 92 and 15 litres of oxygen, clearly that's going to give us far more cause for concern than if they're ventilating in air. Thinking of some of the limitations of oxygen saturations include, we know we work in paediatrics, movement, so they're not great if you've got a screaming, moving baby. Also anemic patients, it's oxygen saturations give us an idea of the saturation of the hemoglobin, don't they? So actually, if you're anemic, your oxygen carrying capacity is significantly reduced. So you might have a good oxygen saturations, but actually it doesn't necessarily mean you're delivering a good amount of oxygen around your body. And we are not able to look at CO2 clearance either. So effectiveness of breathing is getting oxygen in, it's also getting CO2 out. So we just need to be mindful of the fact that just because they've got good oxygen saturations doesn't necessarily mean they're clearing their CO2 as well. And in some cases, a blood gas might be necessary to look at all of these things. But I would argue in most cases, your clinical assessment of a child, looking at a child, will give you as much information as you're going to get in a blood gas. So we just look at auscultation in a little bit more depth, just to look at landmarks. Many of you may well auscultate chests regularly, but I know that not in all environments does everybody auscultate their children's chest. So it's just to look at where you should be listening. So we need essentially to be comparing the two sides, don't we? So when you're listening to the upper lobes are go above the clavicle. So just make sure you're listening high enough when you're listening to the upper lobes. When you're listening to the lower lobes, you actually want to be listening round the back, because as you can see in that second diagram there, the vast majority of your lower lobes actually sit posterior. So you want to be comparing both sides, and you want to be listening front and back. And some of the abnormalities you might hear, and we talked about secretions, we talked about if you've got secretions in your large airways, they're going to sound they're quite noisy, loud crackles. If they're in your smaller airways, you'll hear those as more like quieter crackles or popping noises as the airways are opening and trying to clear through the secretions. Other pathology that might be going on, so consolidation, something like a pneumonia. When you listen, you can hear what sounds like actually increased breath sounds, like bronchial breath sounds. Which sounds you're hearing the resonance from the large airways. You're not actually hearing, obviously air isn't getting into that lobe. If you palpate that chest, you obviously will feel less expansion in the area that's consolidated. In the case of a pneumothorax, you'll obviously get reduced breath sounds on the side where the pneumothorax is and decreased expansion of the chest. If you've got a pleural effusion, so any collection of anything around the lung, you'll have decreased breath sounds on that side and decreased expansion. And then just looking at a classic case of children that we see all the time. So in an asthmatic child, you obviously would expect to hear, and you probably don't need your stethoscope out to hear the expiratory wheeze. When you listen to the chest, you might well hear inspiratory and expiratory wheeze in a more severe disease. You'll hear when you're listening very prolonged expiration as they're trying to force the air out through the narrowed lower airways. Or you might, in severe asthma, hear a quiet or a very silent chest. And when you're palpating the chest, putting your hands onto the chest of an asthmatic, they're often hyper-expanded, aren't they? But very poor inspiratory volume, so not good chest movement when they're breathing in. So we were looking at why, we were looking at what and why we're assessing breathing. Your respiratory e-learning will go into more details about sort of how we escalate care, and you guys will know, obviously it depends on the cause of their respiratory dysfunction as to the treatments that will be required, and obviously we think of things like physio, suctioning, nebulizing, and then escalating of respiratory support, and potentially further investigations that need doing. But as I say, if you look at your respiratory e-learning, that will go into more detail about how you would escalate. And then just quickly as well, we talked about effort of breathing, we talked about efficacy of breathing, and then we know that none of our systems of our body work independently. There's also effects of respiratory inadequacy on other organs. So hypoxia and hypercapnia, so if you're not managing to oxygenate and you're not clearing your CO2, that will cause you to become tachycardic. If that becomes prolonged or severe hypoxia, then we know that turns to bradycardia and as a pre-terminal sign. Hypoxia also causes vasoconstriction and pallor, so you've got a cold, pale-looking child, and then can also cause agitation and decreased level of consciousness. So your respiratory inadequacy has an effect on all your other organs as well. Okay, so moving on from breathing, we're obviously going to go to C because we know our alphabet, and we're going to talk about circulation. So here, what are we looking for? So we're looking for signs of an inadequate circulation. This isn't just about your heart, this is about your circulation and whether your heart is managing to pump enough blood around your body with the oxygen, with the nutrients that your cells, your tissues require. So what we're looking at, how do we assess? We look at the heart rate. again, we're in paediatrics. Is their heart rate normal for that age of child? What's the trend of their heart rate? We know in children never to ignore tachycardia, because increasing heart rate is how children increase their cardiac output. So you should never ignore a child that's tachycardia. You need to look for a cause of tachycardia. Are they in a normal rhythm? Are they in a sinus rhythm? Is it fast? Is it slow? Or are there any actual abnormalities and it's not sinus? Looking at pulse volume, we do it automatically, then we compare central and peripheral pulses. So in a child whose circulation is inadequate, it will be their peripheral pulses that start to decrease first. And if you're comparing the two, you may not even feel peripheral pulses, but if your peripheral pulses are starting to get weaker, then you're concerned that their circulation is inadequate. Again, putting your hands onto the child, you can't assess a child without touching them, without actually feeling them. So are their hands and feet warm? Are they well perfused? If they're not, as you feel up the limb from the hands going up the arm, can you feel a warm, cold demarcation, so you can feel where the circulation is good to and where it's poor? And the same when you're going up the feet. Capillary refill is a little bit of a weak sign, because if the environment is cold, then your capillary refill will be decreased. But you use it in conjunction with other findings. So particularly your central capillary refill time is more sensitive than your peripheral. And then we all know that blood pressure, dropping blood pressure, is a really late sign. You have compensatory mechanisms in your body that you've lost 25% of your circulating volume or more before you start to lose your blood pressure. So if their blood pressure is low, that's a very ominous sign. So just another quick question, just to interrupt this a little bit and to stop me talking the whole time. But just think, when you're assessing circulation, when you've got a baby or an older child that you're concerned about their circulation, are there signs that may lead you to suspect that the child's circulation is inadequate because they're in cardiac failure or because they've got an underlying cardiac defect? So just think about that, and that's coming up in a couple of slides. Let me know if questions come in. Oh, she says. So, okay, sorry. We're just going to type that question in so you can carry on. Sorry, it's a long question. It's maybe not a very well worded question. my support IT team here are typing it into the chat for you all. Okay, so one question that came up was about slides, and the slides that will all go on to Ocean to Sky, so you'll be able to access them and go through them at another time. Okay. So if circulatory failure is really severe, so you can get acute life-threatening circulatory failure, which is shock, which we again will have met children with, and that's a failure of our circulation to deliver oxygen and nutrients to our tissues, and actually also to remove waste from lactate and things from our tissues as well. And that obviously will have an effect on other systems too. So we talk about systems not working independently from each other. So if you're a shocked child will present with a rapid respiratory rate because of their metabolic acidosis. They'll present with mottled, cold and pale skin because their perfusion to their skin will be reduced because the body is trying to keep their circulation and their perfusion to their vital organs. They may become, if they're getting worse and they're now unable to perfuse their brain effectively, they may become agitated, and their level of consciousness may become decreased. That can be quite subtle, and I probably haven't highlighted it enough during this talk, but this is definitely one of those times where you need to be talking to the parents. You know, I certainly have looked after 2-year-olds who've been shocked with toxic shock, and they're just going to be, not quite as responsible as I expect them to be. But you bring them, ask the parent, and they say no, actually they're not really recognizing me, and that's a real sign to you that a child who actually doesn't appear awful on their observations, but actually that's a really significant sign that their shock is very significant. And also obviously their renal system are, asking their family, have they been producing good amounts of urine, are they, normal wet nappies, or depending on the age of the child. So briefly, again, you'll be aware of this. So we want to, if we've got significant compromise of our circulation, we want to be getting on top of that quickly. So treatment is obviously getting some access and getting fluids in. Fluid bolus is, the volumes that we would use, and we'll in cardiac failure, when there's a failure of the pump, then we will think about perhaps reducing that volume that we're giving, and we'll talk about cardiac failure in a minute. And then inotropes. This isn't the purpose of this. This will be covered later on during the course, talking about more specifics of supporting circulation. So have we got any suggestions of?
Yeah. So we've got a lot of good answers here. So we've got edema coming up a few times. We've got bluish nail beds, cyanosis, breathlessness, laboured breathing, nausea, lethargy, fatigue, poor growth, blood pressure differences in limbs, cold extremities, clammy, history of tiredness whilst feeding, failure to thrive, pre and post ductal SATs in newborns, nail clubbing, absent femoral pulses.
Perhaps I should have got you guys to write these slides, because you've definitely come up with some things that I haven't put on the slides. So brilliant, all really good suggestions. And it's just something to highlight, isn't it, that the child that presents in circulatory failure may have an underlying cardiac issue that will definitely change how we manage them. So the kind of things that I thought about was listening and hearing for a murmur, which so when you're auscultating the chest, if you can hear a cardiac murmur, have they got a big liver as a sign of cardiac failure, isn't it? If they've got an enlarged liver because the liver's become engorged. Raised JVPs when older children, you can see that actually their jugular venous pressure's gone up because they're in cardiac failure, and you can actually see their internal jugular, the side of their neck. But we don't look after many children old enough to necessarily demonstrate that. Have they got, if you've got these investigations have been done, have they got a large or abnormal shaped cardiac shadow on chest? Arrhythmias could be a sign of an underlying cardiac defect. People have talked about a gradient and fall in blood pressures. Obviously, we're talking here about neonates presenting, aren't we? Whether there's something specific going on, they've actually got an undiagnosed congenital cardiac lesion. Absent femoral pulses obviously goes along with that. A difference in pre and post ductal SATs, yes, definitely alarm bells about underlying cardiac defect in a baby. And cyanosis, which all of you mentioned, and then if it's not correctable by oxygen therapy in a young child, you'd be really thinking, a baby, you'd really be thinking about a cardiac defect as well. And yes, I will add some of your suggestions to my slide as well, because you definitely came up with some things that I didn't put there. Brilliant. So that's covered C. And next we move on to assessing D, disability, which you wouldn't go on to assess until A, B and C. You're happy with A, B and C. So disability. So now we're looking at how we recognise potential central neurological failure. And also in this section, we're going to briefly talk about as well how we identify a neurological emergency. As you can see, I've put my question up on the slide there about if you looked after children that have presented with raised intracranial pressure, can you think of some of the signs you might have seen of that as well? So get typing with those. So how do we assess disability? So we do a rapid assessment of level of consciousness, don't we? And that might be, depending on where you work, you might be very familiar with using the AVPU score. So is the child alert, as in the baby in this picture, alert, and you're happy, they're an A. If they're not wide awake and interacting normally, are they responsive to voice? So might not be you again, you might be wanting to use parents and carers here, because toddlers may well just not want to wake up and respond to an unfamiliar voice or a person wearing a strange uniform. So are they alert and responsive to voice? If they're not, we move on to painful stimuli, don't we? So if they're not responding to voice, do they respond to pain? And if they're not responding to pain, then they're unresponsive. And we're going to be, we're very concerned about any child that's not an A on an AVPU score. But if they're P or less, then we really start to reassess some of our other things. Are they able to maintain their own airway? We have to reassess our other systems as well. In many settings, we use GCS or an adapted scale of GCS as well, which just gives us more detail. And if you think about, if you put somebody as a P on an AVPU score, which we say we're very alarmed about if they're only responsive to pain, GCS just gives you that much bit more detail, because when you do give a painful stimuli, what is the response? So that depending on how appropriate that response is, their GCS is going to be graded very differently, and how you're going to manage that child is going to change according to where their GCS is. So if a child's got a decreased level of consciousness, they've got an underlying problem with the brain, or that's what our concern is. They may have an underlying problem with the brain. There obviously will be exceptions to these, and children that may be intoxicated by drugs that either we've given them or they've taken themselves, or they may be postictal after fitting. So sometimes there's an explainable reason as to why their level of consciousness is not normal. We obviously need to continue to assess them to see if they're going to regain a normal level of consciousness. But if we haven't got those issues going on, then we've got an alert to something is going on centrally with their brain that we need to find out and treat. But as well as assessing level of consciousness, there are other things that we assess, and many of those things you do from the end of the bed. So posture. So look, has the child got normal posture, or are they very floppy? Is their tone very abnormal, or are they hypertonic? So we see children with CNS disturbances that have decorticate and decerebrate posturing. So the decorticate, when their hands, they've got high tone and their arms brought up towards their chest, or decerebrate when they've got extensor posturing. It's very abnormal posturing, and that suggests something very critical is going on in the brain. We also assess pupils. So again, this is something you guys will do every day in your practice. The pupils should be equal, shouldn't they? They should be round in shape, an appropriate size, and they should react to light, and they both pupils should do the same things. In babies, we can assess the fontanelle, so that gives us a good idea as to whether there is some raised pressure in the head if the fontanelle is bulging. And then blood glucose also comes into our disability assessment. So do we have any suggestions from the chat about raised intracranial pressure?
Yeah, we had a lot of suggestions and they all come up very quickly. So this is obviously got a lot of people going. So we've got bradycardia, irritability, pupil size differences, headache, vomiting, agitation, reduced GCS, hypertension, confusion, increased tiredness, sunset eyes, just trying not to repeat things, changes in behaviour, confusion, change in pitch of cry, vomiting, weakness on one side, unsteady, change in behaviour, seizures, photophobia, abnormal posturing, papilledema, enlarged head in infants, and decreased mental ability. Wow, well done.
Brilliant. And again, and this is meant very genuinely, but thank you for interacting and thank you for making your suggestions, because there's nothing worse than putting questions out and getting nothing back. Again, I might have to add a few things to my slide. Often people just talk about the Cushing's triad, the bradycardia, the hypertension, the altered respiratory pattern, which we're very familiar with, and we have said to us a lot about the signs, those being signs of raised intracranial pressure. But as you guys will be aware, there are many more signs that will happen before you get the Cushing's triad, and those are really late signs. Hence, you should never, a child that you're concerned about whether they might have raised intracranial pressure, you don't let them sleep and just monitor their vital signs, because you will have missed the stage at which you could have done something. So if we just go round what I've got here, I think everything was probably covered, wasn't it? So pupillary changes, yes, you guys got that. Headache, vomiting, these are classic signs, aren't they? Seizures, yes. In infants, you talked about, yep, increasing head circumference, bulging fontanelle, and the high-pitched cry. Decreased motor function, so yeah, posturing, weakness, strange change in their gait. And yeah, changes in speech, slurring speech. I think you guys got all of that. But as I say, we talk so much about the Cushing's triad. I think it's really important that we recognise all of those signs and symptoms that appear before we actually get changes in vital signs, so that we can highlight this as a neurological emergency and get urgent escalation for that child. So as with every other system, no system exists independently. So if we've got neurological dysfunction, that will have effects on our other systems as well. So we'll see it in other parts of our assessment. So, you know, airway and breathing, a decreased level of consciousness, as we know, decreases that child's ability to maintain their own airway. So as we say, if you're assessing a child's GCS and it genuinely is 8 or less, you need to go back and rethink about assessing their airway, and whether you need to escalate what you're doing for their airway to support it for them. Your respiratory centre clearly is in your brain. So if you've got something going on centrally in your brain, then their respiratory centre may be affected as well. So you get different patterns of breathing with neurological issues. Your temperature is controlled by your hypothalamus. So again, if you've got severe neurological abnormalities, you might find their temperature regulation isn't great. And then cardiovascularly, we know that you get tachycardia and hypertension in seizures. Prolonged seizures will then cause metabolic acidosis. And then we've talked about the Cushing's triad, so raised blood pressure and bradycardia, late signs of raised intracranial pressure. So your neurological system has effect on your other systems, but also your respiratory and your cardiovascular failure have effect on your neurological system as well. So it goes both ways. No system exists independently. Okay, so lastly in our A to E assessment, there's a lot of discussion about what E stands for. I've gone for exposure, but I know different people put different things down for E, so I'm willing to accept anything from any of you guys that you want to say that you would put into the kind of the last of your quick assessment. Exposure to me is, this is the last bit, this is when you do your thorough top to toe assessment of your child. We're looking now for any underlying clues to what is underlying in the disease process if we haven't already picked them up already. The child, you need to look at the child top to toe, back and front. Things aren't always obviously visible when you're looking at a child in bed with their covers up. This is when you talk about checking their temperature. Is it high? Is it low? Is that giving you an idea there might be an infection going on that's part of the picture here? We know that neonates, small babies, often drop their temperature and become very cold with an infection, whereas older children behave more like adults and always have a high temperature. Or is it the environment that's actually affecting their temperature rather than their disease process? Is there a rash to be seen? I mean, certainly rashes, and we used to talk about meningococcal sepsis all the time, which fortunately isn't something we see so much anymore. But certainly these rashes don't appear, or don't often appear, somewhere that's immediately obvious. It's when you strip the child off, take off the nappy in the toddler, that you start to see maybe a purpuric rash that's hidden until you've actually exposed them, look top to bottom. You might see an urticarial rash in a child that's got an allergy. Unfortunately, you might reveal things like bruising and other scars that might suggest non-accidental injury as the root of why this child was presented, or it might be a historical thing that you need to investigate. You also might find things like wounds that might give you an idea to that child's underlying picture, sternal wound or something of this kind, coming from a cardiac background here, but something that might show you there's something in this child's history that you didn't know about. And while you are carrying out this final stage of your assessing, it's just important, obviously, to remember the dignity of the child, and also particularly with small babies to remember they lose heat very quickly. So much as we do need to expose them, to look at them top to toe and back and front, we also need to make sure that we don't let them get too cold while we're doing that. And that is the end of my A to E assessment. So I just want to know if anyone has any questions or anything they'd like to add, or discussion points that they'd like to bring up with anybody else.
Thanks, Jo. That was really great run through. I think it's there's a really good opportunity. Just pause for a moment and think about any questions that you have. I think A to E assessment is so fundamental to everything we do. And some of you, maybe qualified a few years, and actually, I think sometimes this is just good for revision, and sometimes this is good to actually get to a point in your career where you kind of think that you know assessment, but then someone runs through it in a slightly different way and adds something to your assessment that you didn't think about before. So this is a really good opportunity to ask those questions. Actually, maybe you're at a point in your career where you don't feel like you can ask those questions anymore. So this is a safe space for you to be able to ask those questions and nobody take judgment. So just ask anything that's burning, anything you're worried about, please just ask away. This is also definitely not the last time that we'll be going through A to E assessment. We'll be using the basis of A to E assessment in a lot of the patients that we talk about, and the case studies we'll be running through A to E assessment. So it's something that needs to become the cornerstone of this course. You can either type a question into the chat, or you can put your hand up and come off mic and ask the question. We're just going to pause there. It's absolutely fine if you have no questions. I think Jo's probably answered most of them, but we're going to pause there for a few minutes and just to give you the opportunity to have a think about it.
So there's a question there, sorry. So in a critically ill child, how often would you recommend doing an full A to E assessment? It's an interesting question, isn't it? I think it's probably quite difficult to answer. I don't think there's any definite answer to that. I mean, other people feel free to chip in anything they want to say. I mean, I think the basis is that when you first meet that child is to make sure your first assessment that you do is really thorough, so any changes you can pick up really quickly. And when you reassess, like I talked about as an example, auscultation, if their SATs start to drop, if you've done a really thorough respiratory assessment first of all, then when you re-listen and you hear something different, you've got key information, haven't you, to escalate to other practitioners about why you think the child you're looking after is deteriorating. So I would say if anything changes in their observations, in their condition, looking at them, then I would redo the assessment. Or also if you're giving any intervention, so like we often talk about it, you know, something like an asthmatic children, again, that we look after all the time. If they've got they've got a wheeze, they're prescribed some salbutamol, bronchodilators you've given them, reassess. You want to know that what you're doing for that child is actually improving things, because I mean, sometimes yes, it absolutely does, and sometimes it doesn't make a difference, or actually the child's condition continues to deteriorate. So I realise I'm not really answering the question very definitively, but I think it really depends on a case-by-case basis. But I think the key is the thorough assessment at the beginning when you first meet the child, so you're able to reassess and determine which direction that child's condition is going in. Anyone else want to add anything?
No, I think you've put into words far better than I would have done exactly what my answer would have been. But I think, I think sometimes it's worth, definitely you've got to get that baseline. But if later on in the day, if things are happening, things get really busy, there's various things going on and you can't quite get to the bottom of something, and things just don't feel quite right, it's worth just going straight back to a top to toe assessment in case something's been missed. And that's often the point at which that you will pick up on something that maybe that somebody else hasn't picked up on. So not being afraid to go back to it later in the day when things have got a little bit more complicated.
So any other questions, or is that? And I think possibly something I didn't highlight quite as much as I'd like to while I was giving the presentation was that I think in paediatrics, more and more, people may agree or disagree, we see more and more children with complex needs as well. So actually your assessment of A to E may differ and quite a lot with some children with complex needs, particularly things like your neurological assessment. So I know we all do it because we're very used to looking after whole families together, although not quite so much at the moment with the current pandemic. But the one person that's in with them is using the information from those parents about what is their normal neurological status. Even do they normally have any airway noises, because some children obviously do. But at all stages of your ATE assessment, using the carer or the parent, whoever's with that child, to help you make that assessment as to whether they're at their normal baseline or whether actually what you're seeing, hearing, feeling when you're examining them is abnormal for that child. And equally not to dismiss it as something that probably is normal for that child, because actually we shouldn't make those assumptions without checking first with their parents or carers. Okay, so just briefly in summary, if people think of questions later on then or discussions they want to talk about, then feel free to send things later. But just in summary, so the A to E assessment is obviously a systematic approach to assessment. It helps us identify urgent problems before moving on to the next part of the assessment, and it guides appropriate, timely interventions, escalation of care, and summoning of help when we need it for a particular child. And as Stacey has said, and we will continue saying this, it underpins the course. We're going to continue to use and analyse these skills throughout this course. And that is the end of my session.